Okay, can you see? Hello, can you see that? Okay, so we left here yesterday. Okay, so don't forget about that the chemoreceptors, they are located in the carotid body and then the aortic body. So they are sensitive to both oxygen and carbon dioxide, a content of the blood. While don't forget that the mechanoreceptors or the baroreceptors, meaning receptive to the blood pressure, they are located in the carotid sinus and then the aortic body as well. Those are peripheral uh, chemoreceptors and then the mechanoreceptors. Okay, so we also have the so-called central chemoreceptors, and they are uh, usually located, and they are located at the brain, at the medulla particularly, medulla oblongata. And they are very responsive to the carbon dioxide. You know that the carbon dioxide, much more, even much greater than oxygen, is the greatest stimulus for respiration. Okay, don't forget about that. Okay. Well, the cranial nerves that are involved in respiration and in the control of the blood pressure are the cranial nerves 9 and 10, the glossopharyngeal and the vagus. So don't forget about the GV hotel that we have here at Tacloban. So glossopharyngeal and vagus. And don't forget 1, 2, 8, cranial nerve sensory, 3, 4, 6, 11, 12 are the motor cranial nerves, while the 5, 7, 9, 10 are the mixed motor and sensory at the same time. So don't forget to memorize the name of the cranial nerves from 1 to 12. Okay. Don't forget that the clomos cells are the particular cells that are in the peripheral chemoreceptors. So peripheral chemoreceptors, automatic na. So put that in your mind. The carotid body and then the aortic body, they sense oxygen, carbon dioxide, and the pH. So the glomus cells. Next, the central chemoreceptors. So don't forget about it. The effect of the carbon dioxide pressure. Carbon dioxide is the most important factor controlling the rate and depth of breathing. Okay, next. Okay, so the same. Okay, so look at it. Okay, so don't forget glossopharyngeal, the GV. So don't forget about that. This one, don't forget this. No wonder the medulla is the cardiovascular, respiratory, and vomiting center. So the medulla oblongata. So medulla contains the cardiac, the respiratory, vomiting, and vasomotor centers dealing with autonomic and involuntary functions like, for example, breathing, heart rate, and blood pressure. That's how important the medulla oblongata is. So don't forget the aortic bodies, they are there located at the aorta. This is the aorta man. So and then the carotid body here, then it is the carotid sinus, this one. this one, the carotid sinus, this sinus, then the carotid bodies as well. So when you remember, so you will not forget until the rest of your life, when you say carotid body, so O, oxygen, and carbon dioxide, chemical content of the blood. So aortic body, also chemical, oxygen, and at the same time, carbon dioxide. But at the same time, it can respond to, it can also be baroreceptors at the same time. Hmm? The aortic body. But the carotid body, no. The carotid sinus, plainly, a mechanoreceptor or vasoreceptors. And we know that during acclimatization, when we say acclimatization, that is actually this adaptation process that our body would do in order that we can cope up with the changes during ascent or going to the mountain up. So the changes are the following: increase in red blood cells and hemoglobin concentration, increased diffusing capacity of the lungs, of course. So because you have to be delivering oxygen, di ba? Even though the oxygen content is small, uh, our body just needs it, and so it should have an increased diffusing capacity of the lungs. Okay. Then peripheral circulatory system changes during acclimatization. You have an increased tissue capillarity. Actually, there are new capillaries that are formed, which you call it as angiogenesis. Angiogenesis. Okay? So peripheral circulatory system changes. So don't forget about the hematocrit for those who are non-medtech graduates. Sometimes kasi it's for if they're non-medtech or that they have difficulty actually to understand terms. So when we say hematocrit, hematocrit is also known by several other names, is the volume percentage of red blood cells in the blood measured as a part of a blood test. So, for example, this is your blood. Oh, look at this, inside the test tube. Okay. So, the liquid portion, of course, is your plasma. Then you'll notice that there are settled here. They settle down. These are actually your red blood cells. Huh? So this is the hematocrit. This is the hematocrit. This one. While you will notice there that there's a buffy coat of the blood. So this is the buffy coat. This is composed of leukocytes and thrombocytes. This one is the hematocrit. They're actually red blood cells. So we have here the plasma. Mhm. And usually when we get the hematocrit, usually in the laboratory, we can use this like a sort of this tube, it's a microtube like this. So we just get it from the blood, the one that we puncture here at the fingertip, and then so this is of course there's also of course an anticoagulant on this. So you centrifuge that, and then what we settle here is this one. So this is your hematocrit, while this one is your buffy coat composed of the leukocytes and thrombocytes. Well, this one is your plasma. Okay. So though, doctors, when you for example, you have hypoxic episodes, di ba? When you have hypoxic episodes, so hypoxia is the greatest stimulus for the release of erythropoietin, di ba? That is produced by the kidneys. So that the bone marrow, through the help of the erythropoietin, the bone marrow will be producing red blood cells. So one example by which a hematocrit could increase is, or what you call as a decrease in hematocrit, di ba? There's a polycythemia. Polycythemia, there's actually an increase in hematocrit. So one example by which an hematocrit is increased would be that of during acclimatization, when you love to go up the mountain, so you'll notice your hematocrit is high. So you'll notice that it will reach like that, this level here, like that. So that's high. So the hematocrit, therefore, is the proportion by volume of the blood that consists of red blood cells. The hematocrit is expressed as a percentage. For example, a hematocrit of 25% means that there are 25 milliliters of red blood cells in 100 milliliters of blood. So it's expressed as a percentage. So why does hematocrit increase at high altitudes? Because we know we have lower oxygen levels at the altitude stimulate erythropoiesis, EPO, leading to an increased red blood cell or hematocrit. This effectively allows more oxygen, therefore, to be carried to the tissues. So, therefore, don't forget why hematocrit increases. It's simply because, one, there's a stimulus. We are into a stage of hypoxia. I mean, a decreased oxygen content ba when we are going up. And so that hypoxia would stimulate uh, the production of erythropoietin by the kidneys, and that erythropoietin would act on the bone marrow, so that bone marrow would produce red blood cells. And why is it that we have to produce red blood cells? It's simply because the red blood cells, kasi they are the one that would carry the oxygen. Okay. So this stimulates erythropoietin, therefore increasing the hematocrit, the red blood cell count. So for acclimatization, don't forget this, the hematologic effects are increased therefore in red blood cell production. Okay. So stimulus hypoxia due to decreased RBC count, decreased availability of oxygen to blood, or increased tissue demands for oxygen. Those are the stimulus. It depends. So the kidney, and even actually not only the kidney, but and the liver to a smaller extent would release erythropoietin. But usually by the kidney, but don't forget it can also be produced by the liver to a smaller extent. So erythropoietin stimulates the red bone marrow, the red, the red, not the yellow marrow, So the yellow bone marrow does not produce red blood cells. So the red bone marrow. So enhanced erythropoiesis therefore increases therefore your RBC count. So it increases the oxygen carrying capacity therefore of the blood. Okay, next. Again, don't forget the plasma has water, proteins, the albumin, di ba? Globulin, the nutrients, hormones. While the buffy coat, this portion, is composed actually of white blood cells and platelets, and then the hematocrit, definitely, of course, the red blood cells. So normal, 37 to 47 hematocrit for female, while 42 to 52% hematocrit for males. And in anemia, express, of course, in anemia, expect to have a depressed hematocrit, while in polycythemia, you have an elevated hematocrit. So don't forget the term polycythemia. It actually refers to an elevated hematocrit. So whatever state you are, as long as there's an stimulus for the development of an increased hematocrit, you'll develop polycythemia. And one of them would be that you'll be going high the mountains. And it's not, it's very bad to have also polycythemia, because you know what, the the red blood cells are, are settling with each other, so in a compact manner, so that it's tend to be sticky like the ketchup ba, and therefore can it can be obstructive, diba? It can be obstructive in flow, so because it's so sticky, so sometimes usually there are deleterious effects actually that may happen. Okay, so go. And don't forget about the relationship between hemoglobin and hematocrit. Hemoglobin, hemoglobin measures, of course, the amount of oxygen carrying protein in the blood. That's why we need iron, so that we could maintain the hemoglobin, because one of the building structures of hemoglobin will be iron. So even though we'll be having red blood cells, if we have decreased hemoglobin, we cannot go to our goal of carrying oxygen in our blood. So it's useless. So we need to have hemoglobin to measure the amount of oxygen carrying capacity in the blood. Okay. Then hematocrit, it measures the amount of space, the red blood cell, the space, the red blood cells taken up in the blood. It is reported as a percentage. So during ascent or going to the mountaintop, the diffusing capacity of the lungs is increased. It represents the gas exchange capability of the lungs. It measures the ability of the gas to diffuse across the alveolar capillary membrane using carbon monoxide. So, okay ha, so this one. It should have an increased diffusing capacity. And di ba, as I told you, when we go up the mountain, you will have an increased pumping ability of your heart. Why is there's an increased pumping capability? Simply because our body detects kasi that there is little oxygen, di ba? Because when you go up, there's little oxygen man talaga. So it is detected as little oxygen by the tissues, by the cells. That's why the heart would compensate to pump more blood. That's why you have an increased cardiac output actually. And to increase the cardiac output, you should increase your stroke volume or increase the heart rate or both. Don't forget that this is a formula also that is usually seen in the board exam. Cardiac output, I love to call it as cash. Diba? Cash. Diba just cash. So that I will remember cardiac output is stroke volume times the heart rate. Okay, so again, cardiac output is actually stroke volume times the heart rate. So cash. When we say cardiac output, it is the amount of blood that is being delivered per minute. While in stroke volume, the amount of blood that is being pumped per beat and every beat of the heart, per beat. While cardiac output is per minute, in every minute. So to increase the cardiac output, should of course increase the stroke volume or increase the heart rate or increase both. Okay. So when you say angiogenesis, the development actually of more capillaries. So before angiogenesis, this is the one. But after angiogenesis, you'll have lots of new capillaries. And in acclimatization, you'll have actually angiogenesis. So therefore, if you look at this, another circulatory adaptation, is growth of, another circulatory adaptation is growth of increased number of systemic circulatory capillaries, that is angiogenesis, in the non-pulmonary tissues, which is called increased tissue capillary or angiogenesis. This occurs especially in animals born and bred at high altitude. So usually, if you remember in the Andes Mountains, diba, in South America, and even in the Himalayas, diba, and also in the Himalayas, there in India. So there are natives there. So this occurs especially in animals or natives born and bred at high altitudes, but less so in animals that later in life become exposed to high altitude. So it's but not natural when you are born there, you really have more capillaries. And then if you try to look at those people in pictures, they are big. They're like Superman, Superwoman. So they're big. They have bigger faces. Actually, they have bigger heart. So it's because of the acclimatization process. So inactive tissues exposed to chronic hypoxia, for example, In active tissues exposed to warning hypoxia, the increase in capillary is especially marked. For instance, capillary density in the right ventricular muscle increases markedly because of the effects of hypoxia and excess workload on the right ventricle caused by pulmonary hypertension at high altitude. A cellular acclimatization in animals native to altitudes of 13 to 17,000 feet, cell mitochondria and cellular oxidative enzymes are slightly more plentiful. So if you are actually a native, or for example, a native, di ba, in the river, so you're in the Andes Mountains, you'll have more cell mitochondria and cellular oxidative enzymes simply because you are working a lot. Your body is working a lot in order to compensate, in order to grasp more oxygen. Huh? So therefore, you have more mitochondria and cellular oxidative enzymes. Therefore, it is presumed that the tissue cells of high altitude acclimatized human beings also can use oxygen more effectively than can their sea level counterparts. So even though the oxygen is not, meaning to say, even though the oxygen is not that much because because they've been acclimatized to it, and then their body develop more mitochondria, therefore they can utilize more effectively even the small oxygen that they can get. So that's a part of their living. So natural acclimatization of native human beings living at high altitudes. Many native human beings in the Andes and in the Himalayas live at altitudes above 13,000 feet. One group in the Peruvian Andes lives at an altitude of 17,500 feet, very high, and works a mine at an altitude of 19,000 feet. Many of these natives are born at these altitudes and live there all their lives. So in all aspects of acclimatization, the natives are superior to even the best acclimatized lowlanders, even though the lowlanders might also have lived at high altitudes for 10 or more years. Acclimatization of the natives begin in infancy, so it's a part of their lives. So the chest size especially is greatly increased. The chest size is greatly increased, whereas the body size is somewhat decreased, giving a high ratio of ventilatory capacity to body mass simply because the chest, because they use it for breathing. So they have a bigger uh, chest compared to that of their, let's say, their stomach. In addition, their hearts from birth onward pump extra amount. They pump, di ba? You have increased cardiac output, so they're considered larger. So they are larger than the hearts of lowlanders. So if you are actually, that's why if you have read in magazines ba, those that are, for example, attending conventions before you're going to, for example, you're going to Bolivia, di ba Bolivia, the Andes are there. Bolivia kasi sa mountainous country, so they would love to go there in advance before the convention because they have to acclimatize, they have to adapt. Because if you immediately begin an activity there in Bolivia daw, in La Paz, Bolivia, their capital, you will find it hard. You find it breathless, you have sleeplessness. Di ba di ba you immediately would wake up. You cannot really sleep well in a high, in a mountain, in a high area because it is a natural it is a natural for a person to wake up because by waking up kasi you can breathe more deeply. If you have, if you will be just be sleeping, the problem with sleeping, yes, you can breathe, but the problem is that it is a shallow breathing only, not really deep. But remember, it's all right to be having a deep breathing because we have a lot of oxygen. The oxygen content is normal, but up it is the oxygen content is low. I mean because of low pressure, di ba? So you just have to awaken up whenever we are in the mountain. You can actually, even when for first timers to Baguio, di ba? First timers for going to Baguio, they find it difficult as well to be sleeping. And they would always wee because, di ba? They would always urinate because, uh, di ba? There's a lot of activity to be done by the heart and the lungs. So they would urinate always. And you feel that immediate tiredness when you're in Baguio, di ba, for the first time. Okay. So in animals native to altitude of 30 to 17,000 feet, cell mitochondria and cellular oxidative enzymes are slightly more plentiful than in sea level inhabitants. Therefore, it is presumed that the tissue cells of high altitude acclimatized human beings can also use oxygen more effectively than can their sea level counterparts. So, therefore, as you acclimatize, you have an increased pulmonary oxygen diffusion capacity. Oxygen delivery is good towards the tissue so that the tissue can utilize it. Then more mitochondria, okay, because it needs to work harder. So look at this. So look at the faces or the features or the habitus of the people or the natives in Andes or Himalayas. They're bigger. They're like males, even they're women. Okay. So expect more mitochondria, they have bigger heart here. Okay. Their muscles will be bigger simply because you'll be working harder kasi you'll be working harder. Okay. So therefore your muscles will hypertrophy or become bigger. So it's just self-explanatory actually if you know actually the principles behind, you can explain why do they look like that. Okay. So look at their facing. Okay, the babies, they are red because of polycythemia. Look at the polycythemia. They are red. Okay, red faces. Okay, so they have bigger hearts. Okay, so therefore, overall, as you acclimatize, your blood becomes thicker because you have increased hematocrit. You urinate more often because your body needs to get rid itself of excess body weight in the form of urine. Red blood cells carry oxygen in your blood. More RBCs make your blood thicker. Heart starts beating faster simply because, diba, in your tissues, they know that the tissues, the cells, they have lesser oxygen kasi normal content. So therefore, it is detected by your body, by your heart as they just need it. So the heart would try to pump more. Okay. So these are the normal responses to altitude gain. If it means your body is coping well with altitude. Altitude sickness occurs when your body doesn't cope with altitude. So that's why we develop, other people kasi cannot cope up. Other people find it difficult to cope up. Other people find it to have acclimatization. They find it hard. So they develop acute mountain sickness and chronic mountain sickness. Acute mountain sickness and chronic mountain sickness. It's a chronic longer time already. So acute mountain sickness, acute and high altitude pulmonary edema. So a small percentage therefore of people who ascend rapidly to high altitude becomes acutely sick simply because it's within their system. They just cannot adapt immediately. So they could become acutely sick and can die if not given oxygen or removed to a low altitude. The sickness begins from a few hours up to 2 days after ascent. Two events frequently occur, meaning acute mountain sickness. They develop a sickness, but only acute. At least after 2 days, they are already well. They can already acclimatize. So the acute mountain sickness are with what two events frequently occur in acute mountain sickness. You can have acute cerebral edema, meaning there will be an inflammation of the brain. Okay, acute cerebral edema. This is believed to result from local vasodilatation, meaning the blood vessels will open up of the cerebral blood vessels because of the hypoxia. local vasodilatation because of the hypoxia. Because the cells kasi are needing oxygen ba, so the tendency would be the blood vessels to dilate in order that you can give the blood and eventually the oxygen. Dilatation of the arterioles increase blood flow therefore in the capillaries, thus increasing capillary pressure, which in turn causes fluid to leak into the cerebral. So di ba, your tendency for your blood vessel will be to dilate. So if you dilate this one, so that you can flow, so that blood could flow there, because your tissues just need oxygen. They just need oxygen, so you just have to be pushing that. So you for the capillaries would tend to dilate, to widen up. And so when there is fluid going there, they have an increased pressure. It's of the you will develop an increased hydrostatic pressure. So what will happen if you have an increased hydrostatic pressure here? It will transudate. They will go out of the blood vessel. So remember, this is the interstitium, di ba? If this is the interstitium here, you will have fluid in the interstitium. So you'll have interstitial edema. And for example, this is your brain cells. So from the interstitium, they can go to the cell of the brain. So you'll have cerebral edema. Di ba? Edema can develop, di ba? If you remember, from an increased hydrostatic pressure, from a decreased protein, from lymphatic blockage. So there are many causes. So here, what is being described here is as the cause of the edema would be from the increased hydrostatic pressure because of the vasodilatation that happens. Because there was a need. You need to have oxygen here. So if you try to read it again, it is believed to result from local vasodilatation of the cerebral blood vessels caused by hypoxia. So dilatation of the arterioles would increase the blood flow into the capillaries, thus increasing capillary pressure, which in turn causes fluid to leak into the cerebral tissues. The cerebral edema can then lead to severe, of course, disorientation, another effect related to cerebral dysfunction. Another one would be the acute pulmonary edema, almost the same theory. So acute pulmonary edema. The cause of this is still unknown, but one explanation is the following. The severe hypoxia causes the pulmonary arterioles to constrict potently, this time the arterioles, the pulmonary arterioles to constrict potently, but the constriction is much greater in some parts of the lungs than in other parts. So more and more of the pulmonary blood flow is forced through fewer and still unconstricted. So the tendency is this. So remember, the severe hypoxia causes pulmonary arterioles to constrict potently. So therefore, there's an area of constriction. And that area of constriction is much greater in some parts of the lungs than in other parts. So therefore, more and more of the pulmonary blood flow is forced through, they will try to find a place by which there is no constriction. So they would go through fewer and fewer still unconstricted and pulmonary vessels. They want to go to those that are not yet constricted. So the postulated result is that the capillary pressure in these areas, therefore, of the lungs become especially high. For those areas that were not yet constricted, so therefore, because there's a preferential flow going there to those not yet constricted, so therefore, you will have an increased hydrostatic pressure in these areas. So therefore, it will go to the interstitium, producing an interstitial edema, and later on, they will go to the alveoli, di ba? To the alveoli, the fluid, so that you will have the same time, the pulmonary edema na. The pulmonary alveolar edema. So they have discussed that before, di ba? So therefore, extension of the process, the postulated result is that the capillary pressure in these areas of the lungs become especially high and local edema occurs. So extension of the process to progressively more areas of the lungs leads to spreading pulmonary edema and severe pulmonary dysfunction that can be lethal. Allowing the person to breathe oxygen usually reverses the process within hours. So here's an example, doctors, of a patient with a cerebral edema. If you try to look at this portion here, this one, you have here these are the sulci. This one, sulci. This one is the area of the gyri. These are gyri. These are sulci. Look at these areas. In these areas, you cannot anymore see this like this sulci, and Look, no more sulci, meaning to say that fluid accumulated in this area to the extent that the sulci disappeared. So that's why you will have here the areas of edema. Okay. Here, there's no edema. Here, there's edema. So those are just examples. Huh? So you'll have cerebral edema. And look at this. Edema, narrow sulci. Narrow sulci simply because why? These are the sulci, di ba? Why would the sulci would become narrow? Simply because there is lots of fluid already here in the cells, within the cells of the brain. Di ba? So therefore, the gyri would flatten. The gyri would flatten simply because they're filled with fluid because of the edema. And therefore, because of the lots of fluid here, the gyri, they could compress actually your sulci. Therefore, you have the so-called narrow sulci. And that is one of the things I've seen in cerebral edema. So look at this. Oh, okay. Here, look, the swollen, the cortex of it appears swollen. This one, oh, because of lots of fluid. Okay, so the tendency would be they try to narrow down the sulci. Narrowed sulci. Here, the sulci are still good. Okay, no problem. Some areas, there are no problem. But here, there are some areas in which there is narrowing of the sulci. Simply because the surrounding, the gyri are filled with fluid. That's cerebral edema. Here naman, so don't forget, Dr. Why is it that they are so white here? It's because the alveoli are filled with fluid. Alveoli are filled with fluid. So you'll have pulmonary edema. Look, why are that the blood vessels are so accentuated here? It's because you have pulmonary congestion. Diba? Before you develop an edema, diba, you have congestion man muna. Diba? These are the pulmonary vessels. So if you have pulmonary vessels, if you have increase in the flow there, so you will have congestion because if you have it later on, just like traffic jam, diba? You have lots of cars going there, so lots of fluid going there, you'll have traffic jam. So that's congestion. Later on, because this is naman fluid naman, of course, with red blood cells, so you'll have increased hydrostatic pressure here. So what will happen? So this trafficking jam represents this one, the accentuation. And then the whiteness here developed simply because increased hydrostatic pressure in this area, fluid will be going to the interstitium first. Okay, that's why whiter here, whitish, because of interstitial edema, diba? Because fluid will be going out. And then, if they go to the alveoli, you'll have alveolar edema. That's why here it's more white, meaning to say that the alveoli are already also filled with fluid. So all in all, you have pulmonary congestion, interstitial edema, and pulmonary edema. It can happen in high altitude. During going to high altitudes, if you develop acute mountain sickness. But good, it can be treated. So, you can put the patient to hospital, you can have diuresis. You try to let the fluid go out to the urine because you have a fluid collection. So you just have to diurese. So changes include cerebral edema and pulmonary edema. So this is also pulmonary edema, more edema. So like the bat wing, diba? The bat wing pattern. This is your heart. This is your pulmonary edema. Okay. So in microscope, for Dr. Lasaka, so actually these are alveoli. These are alveoli that's filled with fluid. You see this parang pinkish thing. So they're actually fluid. So there's a pulmonary edema actually. Supposed to be there should be none for this like this. It should be white only, meaning there's air, but here it's pinkish because there's fluid. So what again? Chronic mountain sickness. If in acute, only short time, mga 2 to 3 days, then the patient can now adjust. But in chronic mountain sickness, Occasionally, chronic is a longer, meaning longer mountain sickness. Occasionally, a person who remains at high altitude too long develops chronic mountain sickness in which the following effects occur. Understandable. You don't have to, but we don't get bothered with this. Understandable. The red blood cell mass and hematocrit becomes exceptionally high. The pulmonary arterial pressure becomes elevated even more than the normal elevation that occurs during acclimatization. So remember, di ba? Okay, before we proceed, the right side of the heart becomes greatly enlarged. I'll explain this one. The peripheral arterial pressure begins to fall. Then the congestive heart failure continues, ensues, and death follows. So remember, Doctor So, this, if for example, this is your lung, this is your lung, right lung, di ba? This is your left lung. And di ba, we have here your heart, di ba? Your heart. So this is your right atrium here. You have here your right ventricle here. Then you have here your left ventricle here. Diba, it's going posteriorly. It will go down there, the posterior. The main bulk is the left ventricle, but it's going down the posteriorly. Pupunta yan sa likod. Ha? So you have here your left atrium. So don't forget that this is the pulmonary, this is the right ventricle. Remember that the right ventricle, it would give way to the pulmonary, right main pulmonary artery, di ba? The right main pulmonary artery. So if this right main pulmonary artery, because they would be delivering the oxygenated blood to the heart, right? The pulmonary artery. Then after that, from the lungs, smaller blood vessels, they will become your pulmonary veins. Pulmonary veins, di ba? Two here on the right, two in the left, they will become the pulmonary veins. They carry now the oxygenated blood. And they just go to the left atrium, di ba? To the left atrium here. Part 4. The problem in chronic mountain sickness is that you develop constriction of your pulmonary arteries. Your pulmonary arteries constrict. So if your pulmonary arteries constrict, meaning they narrow down, what will happen? The blood from the right atrium, because this is already constricted, the pulmonary artery narrowed, meaning it's already constricted or narrowed. The blood from the right atrium, from the right ventricle, right atrium, then go to the right ventricle. So from the right ventricle, it cannot anymore pass. It cannot anymore pass going to the right. It cannot anymore pass the right pulmonary artery. So what happens? Because it cannot pass anymore, it will have a backflow. You will have a backflow going to the right ventricle. So therefore, the right ventricle will have an increased pressure because of the fluid going back there, because it cannot pass. So what will happen? You will have an elevated right ventricular pressure, and that elevation would lead to enlargement of the right ventricle. So it will have an enlarged. So that's why the right side of the heart becomes greatly enlarged. So if you will enlargement of the right ventricle, it will also backflow to the right atrium, natural, diba? Going to the right atrium. So you will also have an enlargement of the right atrium later on. So meaning that's what you mean by the right side of the heart becomes greatly enlarged, and that simply because there's no more flow going there, so lesser flow going to the pulmonary, a lesser flow going to the pulmonary veins. So if there is lesser flow going to the pulmonary veins, lesser flow going to the left atrium, then lesser flow going to the left ventricle. And if you have a lesser left ventricle flow is low, then you'll have a less circulation going to the aorta. So if you have a lesser circulation going to the aorta, how can you give pressure to your peripheral, meaning to the peripheral arteries, but the arteries here in the periphery, the distal portion. So therefore, the peripheral arterial pressure begins to fall. Congestive heart failure continues simply because there's congestion here. Remember, there's congestion happening here because in the pulmonary artery, remember, in the pulmonary artery, it was constricted. The pulmonary artery was constricted. So then daming of blood in the right heart, the right ventricle. So what happens is you'll have pulmonary arterial congestion. So therefore, no wonder you can have congestive heart failure changes, and death, of course, follows the person is moved to a lower altitude. Unless the person is to move to a lower altitude, you will have death actually. So self-explanatory. So the causes of events are probably threefold. First, the red cell mass becomes so great that the blood viscosity increases severalfold. This increased viscosity tend to decrease tissue blood flow, diba? Because it's like a ketchup. It tends to decrease the tissue blood flow, so that oxygen delivery also begins to decrease. Second, the pulmonary arterioles become vasoconstricted because of the lung hypoxia. This results from this results from vascular constrictor effect that normally operates to divert blood flow to the oxygen. So don't so that's not just get lang my explanation so that you will not get lost. So and then and then if you try to look, it's good just try to remember. Just try to remember this one. So you okay. Effects because of rapid change in the velocity of motion of blood in airplanes or spacecrafts. You don't have to. So okay. So so doctors, look. This is a heart. This is the heart. This is your aorta. This is your aortic knob, aorta. Doc, what's aortic knob? Because what you just remember is, diba, ascending aorta, then the arch of aorta, then what you remember is the descending thoracic aorta, and then until it becomes your abdominal aorta, diba? Just what you remember. So, and then the arch of aorta, diba? So for the arch of aorta, they have the ascending portion. Both are the branches of the ascending portion, the right and left coronary arteries. And then for the arch of aorta, what you remember is that, doc, the branches of the arch of aorta, doctor, are, we have the brachiocephalic artery, doctor, or the innominate artery, which gives rise, doctor, to your right common carotid artery and your right subclavian. Don't forget about that. This is very basic. This is very basic. So I love to stimulate your mind through basic ones, because that through the basic ones you can now memorize the other blood vessels. I want you to start with the basic ones, because this will give you strength. Because the problem is that you don't remember kasi the basic ones, the very, very important ones. That's why you find it difficult to memorize the blood vessels, simply because you're already jump-packed and you're already afraid and you get lost. Begin with the feasible things. Begin with what is feasible. Begin with what is basic. Okay, so this is the branches are the innominate artery, which is composed, which gives rise to your, so I don't forget this one, brachiocephalic artery. My students would like to say that there's only one bra daw of a girl. Not normal, only one bra of a girl, of a woman. Only one. So only one brachiocephalic artery, or the innominate artery, which gives rise to your right uh, right subclavian and the right common carotid. Okay. Another branch is your left common carotid. Left common carotid. And another branch is your left subclavian. So there are, therefore, if I ask, what are the three main branches of the arch of aorta? One brachiocephalic artery, or the innominate artery, then the left common carotid artery, then the left subclavian. That's correct. So what are the two branches usually of the ascending aorta? The right and then the left coronary arteries. They are the ones that, diba, that supply the heart. Another favorite board exam question is this, that the right coronary artery daw comes from the anterior aortic sinus. I love to call this one the right coronary artery, while the left, I love to call this left, while the left coronary artery comes from the posterior aortic sinus, P, while the one aortic sinus anterior is the right. So the right common carotid artery, the right coronary artery comes from the anterior aortic sinus. So always put that right, while the the left coronary artery emanates from the posterior, posterior aortic sinus. Mind you, it appears in the board exam, and many are got trapped. So memorize memorize it that way. Right, A, anterior aortic sinus, left, posterior aortic sinus. Okay? And what are the branches of the descending thoracic aorta? Actually, there's an action thing. It's like an action song here for the RAM here. So one would be esophageal artery. Another one would be bronchial. You try to press your neck. You practice on not the press. Of course, do not press. You try to handle your neck. You are actually as if you are holding there your esophagus, di ba? The esophagus within the neck. So esophageal artery. And look, if you're pressing that one also, you will see there the bronchus, di ba? The bronchus, it's like di ba the trachea kasi the larynx, trachea, the bronchus. So as if when you said the trachea, as if there's a bronchus, so bronchial artery. And then, of course, the intercostal arteries here. Intercostal arteries. Here. Intercostal arteries. And mediastinal arteries. Look at this. This is a mediastinum man ini. Heart, di ba? Don't forget, because you might get lost, You know what? I say this because even fourth-year students or those taking the board exam, they don't know what is this. That the thoracic cavity is divided into two portions, the lungs and then the mediastinum. So the whole thoracic cavity is composed of the lungs and then the mediastinal structures. What are the mediastinum? The mediastinum actually refer to the heart, to the trachea, to the bronchus. So the lymph nodes there, the hilum. So they are your mediastinal structures. So therefore, so that you're not difficult to memorize, give me branches of the descending thoracic aorta. Doc, bronchial artery, doc, esophageal artery, intercostal arteries, the vessels, doc, and then mediastinal. There are, yes. So those are. So others you can actually start na memorizing with others through things that are enjoyable and basic. Okay. If you only have one pulmonary artery, if you only have one brachiocephalic artery, one bra, you have two brachiocephalic veins naman. You have two brachiocephalic veins. The brachiocephalic veins, look at this, So, brachiocephalic veins, there are two. Diba, women, normally they have only one bra. Only one bra. So, the bra looks like this naman, diba? Diba, Cindy? The bra looks like this, diba? Diba? The bra is like it's like an eyeglass, diba? Like that. But you only have one bra, but one pair. Like that and like that, diba, Yani? Okay, one bra of a girl. But there are two brachiocephalic veins. That's the most important. Two brachiocephalic veins. Okay. So normally. So the right brachiocephalic vein and then the left brachiocephalic vein, when they join, you will have the superior vena cava. The superior vena cava. So, but before it becomes the right brachiocephalic vein and the left brachiocephalic vein, so the right brachiocephalic vein and the left brachiocephalic vein, it will be joined by it will become the right internal jugular vein and then the right subclavian vein. The right internal jugular vein and then the right subclavian vein. So here also, you have your internal left internal jugular vein and then the subclavian, left subclavian vein. Don't forget. And. So you will never forget it. Add what you learned before. Where, Yani, if you remember, where would the right the right lymphatic duct and then the left thoracic duct drain into? It would drain into
At
in
the
between.
bifurcation.
Yes, the
Okay.
bifurcation. Very good. So apply
Right.
it immediately, doctors. To all of you, apply it immediately. One technique kasi of learning actively and not forgetting is apply immediately what you learn. Do not try to forget kasi and not apply it because you will tend to, it means nothing, di ba? So and then when you already remember this one, you tend to also to remember the system na Kylie, the mucomediastinal trunk, the function of the lymphatic system, and then you enjoy this kind of learning kasi the moment kasi you won't do a technique or enjoy learning, a lot of fun, you will forget. Okay. And another fun, di ba, if you're in your neuroanatomy, di ba, for the CSF drainage, if you remember, di ba, Liani, di ba, Ilani, the CSF,
Yes,
it's the
Doc.
same. Di ba, it will drain here. Di ba, it will drain in this area here, di ba?
Yes,
So,
Doc.
so therefore, to all of you med one, please put this whole into your whole heart, okay? And then apply, di ba? Di ba? We place there for our med one, for our di ba? If you remember, there's an abnormality. There's an abnormality, di ba? The snowman's heart. If you remember the snowman's heart like that, di ba? The snowman's heart is this. There's an abnormality at this time because in the snowman's heart, your function is, look, what is this? This one. That's actually the superior vena cava that is dilated. Doc, what is this one? That is what you call as the horizontal vein. Doc, what is this one? That's the vertical vein. Okay, so the problem that why it is like that. This horizontal vein is actually a innominate vein. This time, because it is anomaly, you only have one innominate vein instead of two. How come, Doc? Don't be questioning anymore because that is a congenital anomaly. So we cannot, it just so happened that it just got only one. So this is Doc, this is the horizontal vein, is the innominate vein, only one. Therefore, that means to say that this one, the left, the instead of two veins, only one vein. It developed this one. So therefore, it means to say, Doc, that the left subclavian and the left common carotid, the left internal jugular, and the left subclavian, yes, they will drain here to one side, the other side of corner of the innominate vein. And the other one will also be going here. It will drain there. The right internal jugular and the right subclavian here. And therefore, this one by which these people have joined here, they will now become, they will go to the superior vena cava. And Doc, what is this? What is that? What is this, Doc, that developed here? Because I told you, diba, the most common type of snowman's heart is is supracardiac, meaning above the cardiac, above. So therefore, instead of that, di ba, normally, if this is the heart, if this is the left, atrium, if this is your left atrium, normally, the pulmonary veins, di ba, right, and that in the right, two. They will go there, and from the left, there are two, di ba, pulmonary veins. So, four pulmonary veins at all. Normally, they would connect to their left atrium. But in snowman's heart, supracardiac type, meaning above, the supracardiac type, the pulmonary veins, they would not land there. They would not land here. They would not. They would instead go 4. 1, 2, then another 1, 2. Then they will be joining all together. They would form a tube, which we call as the vertical vein. Vertical. So this vertical naman. This, okay, so this therefore becomes a vertical vein, which is coming from the joining together of these 4. Because they did not land at the left atrium. And then, therefore, they would become the innominate vein. Only one. To be joined here by with this right and left with the jugular, like this one, diba? This one, among yan. There, and then it will become the. So therefore, this one, these are dilated. These are dilated, of course. So this becomes the head of the snowman. Where's the body is the heart, of course. There is also one. If for example, Yanni, you will be asked, what is the most common variant of the aortic arch? What is the most common variant, congenital variant of the aortic arch?
The cow shape.
Yes, very good. You are really a board placer. The bovine aortic arch, bovine.
Yes. Bovine.
The bovine is that instead of this one, look, normally it's like that. We only have one bra. This one is joined. They have one common channel. This one, just transfer this left common carotid here. Just transfer this ending to here. So let's put that one. Let's put that one. So it becomes like that. So therefore, so let's put that one like that. Let's put it that one. Let's put it that one. So therefore, there's a common stem. There's a common stem here. There's a common stem between the brachiocephalic artery, and then the left subclavian. They will be joining together so that they will just have one common trunk. So therefore, this becomes like a sungay of the cow. That's why you call it as a bovine aortic arch. So the most common congenital variant of the aortic arch is the bovine aortic arch. Okay, so this, you know what? This learning makes a lot of fun, and at the same time, you learn a lot because they appear in the board exam. So look at this, doctors. So, wow, doc, the pulmonary supposed to be, okay, I'll let you learn a normal. Okay, this is the normal. This is the normal chest pay lateral view. Always remember this, put this in your mind, because 2 weeks from now, 1 month from now, you'll be starting already the third bimonthly, and then after that, you'll be going to second year, and then we'll be starting with radiographic anatomy. So put this here. This is the right atrium. Put this in mind. This is the right. This is not the right ventricle. This is the right atrium. This portion is your right ventricle. Here. This portion is your left ventricle. The left ventricle kasi goes posteriorly. That's why this is your left ventricle. It goes posteriorly, di ba? I so told you like that. Okay, like that. So therefore, this one is your right ventricle. This one. This is your sternum. This is your sternum. This is your thoracic spine. Okay, So, look, where is the left atrium? The left atrium is somewhere here. So, this is the left atrium somewhere here. Okay, ha? So, right ventricle, just a preliminary, just a preliminary. You don't have to force issues. Just a preliminary, so that at least you'll not get. Actually, you'll not be foreigners next because I've started actually already little by little. So right ventricle is the left ventricle. This is your left atrium. So this is your left atrium here. This is your left ventricle. This is your right ventricle. Okay, ha? So, Doc, what is this? Supposed to be this is your shadow of your aortic knob. Doc, what is aortic knob? Di ba, which I said, di ba, kanina, this the ascending aorta, di ba? Doc, look at this. This look ascending aorta. This is your arch of aorta, arch. This is your descending thoracic aorta. Somewhere between the portion of the ascending aorta and then the descending aorta, in between that portion of the arch of aorta and the beginning of the descent of the aorta, descending aorta, this is your aortic arch. And therefore, it can be seen as this way. This is like that. That is abnormal kasi. So therefore, this is a aortic knob. That's the aortic knob. So the boundary between the arch of aorta and the descending, so that's aortic knob. That's what you call. This one, the bulge, immediately below your aortic knob is your pulmonary trunk. Pulmonary trunk, by where you develop your right pulmonary artery and left pulmonary artery. Pulmonary trunk gives rise to your left main pulmonary artery and the right pulmonary artery. So your pulmonary trunk. And this is your left atrial appendage. Sige lang. As the peripheral portion of your left atrium, left atrial appendage. And this is your left ventricle. Ah, okay. So therefore, if this is the pulmonary trunk, doctors, therefore this is the right main pulmonary artery, while this is the left main pulmonary artery. Pulmonary trunk. So therefore, this is your right main pulmonary artery, and this is your left main pulmonary artery. Okay. Look at this. It is not dilated because normally it is 17 to 20 mm. Look at this. And normally, look at this. The pulmonary trunk is bulging, yes. The bulge immediately below the aortic knob is always your pulmonary trunk. Yes, that's true. So, but it's not really bulging. This is your left. My God. This is a main pulmonary artery. This is a pulmonary trunk. It's so dilated. Because I told you, the bulge immediately below aortic knob is your pulmonary trunk. It's so dilated. And look at this, the right main pulmonary artery. It's so big. It's dilated. It's dilated. Okay. And that is because there is some sort of obstruction here. So could it be that the distal portion of the pulmonary artery here is constricted? That di ba, as I told you, in acute and chronic. It can happen in acute and chronic mountain sickness, especially chronic mountain sickness, di ba? The arterioles, the pulmonary arteriole becomes constricted. Yes, that's why it's constricted here. That's why the proximal portion gets dilated because there's a constriction in the distal portion of the pulmonary artery. Okay. So that's why it's so big. And remember, it's so big. Because it's so big, you have increased hydrostatic pressure here. Di ba, Yani? Very, very much increased hydrostatic pressure here.
Yes.
So what will happen? It will be transmitted going to the pulmonary trunk. That's why your pulmonary trunk is so big. Ah, okay. So therefore, pulmonary arterial hypertension occurs. And if you have hypertension, of course, expect there's congestion in this area. So you have pulmonary arterial congestion and hypertension. And it can happen in chronic mountain sickness. As an example, huh? Okay, I'll just lobat. So, will this your doctors, huh? So, that's it, huh? So, again, look at this. This is your thick knob. This is your pulmonary trunk. It's dilated. Look. This is your because look at this, doctors, because your normally I'll just add, ha, okay, I'll just add, di ba, the normal, I told you kanina, di ba, that this is your left ventricle, this is your right ventricle. Normally you see this black thing here, that's what you call as clear space, because the portion of the right ventricle here almost comes in contact with the sternum, with the sternum. It's normal to have a clear space here, 50% clear space, 50% fullness. This is the fullness here. 50% fullness here, 50% clear space. That means to say that your right ventricle is normal, not enlarged. Okay, ha? Simply because you have 50% clear space up and 50% fullness down. Because this one is your anterior portion of your right ventricle on the lateral view, while this one is also an anterior portion of the lateral view of your right ventricle. And that normally, the apex of the heart is the left ventricle. The apex of the heart kasi, the left ventricle is an apex. Normally, the apex, this one, is downward, pointing downward the apex. Okay. Look at this, doctors. Hala, doc, why is it that the apex of the heart is already uplifted here? Not like that. Okay. That is one of the features of right ventricular enlargement. If the right ventricle would enlarge, you will have actually a uplifting of the cardiac apex. This was another story. You have your right atrial enlargement. But anyway, this is an introductory. Huh? So, different from, look, the apex is uplifted. Yes. Because as I told you, di ba, Dr. Ilani and the whole Med1 class, di ba, if look at the pulmonary artery is dilated, simply because there's somewhere obstruction here. Could it be the distal portion? Could it be from a disease process of the lungs that try to block your pulmonary artery, therefore increasing the pressure in the pulmonary artery? And because of that, you will have transmission, you will have an increase in you will have a dilated pulmonary trunk. Okay? So what happens? Because you have an increased pressure here, di ba? I told you, the pulmonary artery, the right pulmonary artery comes from the right ventricle. So therefore, you will have an increased pressure in the right ventricle because they will backflow. They will backflow. Huh? They will backflow. So you will have an increased right ventricle, and even later on, even your right atrium. So therefore, you will have a right ventricular enlargement. Right ventricular enlargement because we have too much pressure here because of the backflow. So therefore, you will manifest right ventricular enlargement. One of the features of right ventricular enlargement is the upliftment of the cardiac apex, like this, like that, uplifted apex. Huh? While, Doc, how will we differentiate enlargement of the left ventricle from the right? Because you have already taught us right ventricular enlargement. Left ventricular enlargement is like this. Naman, shmoo. Shmoo is a cartoon character during the 1950s. Shmoo. Look at shmoo. Look at here. So, you have an enlarged heart actually. Enlarged heart with further lateralization of the left ventricle with still the apex pointing downward. The normal appearance kasi of the left ventricle is this. Oh, look. Normally, the left ventricle, this one is not an enlarged heart, not enlarged heart. That's why I'm going to there. Because I will teach you na lang next time, how to get it. This is not an enlarged heart, but this is not an enlarged left ventricle because it's normal. Look at this. Normally, the left ventricle goes laterally with the apex pointing downward. But if you have an abnormal left ventricle, it is further. There's further lateralization of the left side of the heart with still the apex pointing downward. That further lateralization, because you have an enlarged heart hindi naman, uh, it's just like the portion of smooth here. So that's what you call a smooth side. So much more for that. Anyway, so here you have a pulmonary congestion. Look at this, huh? Accentuation. And normally, you don't see that in a normal. Look at the normal. You don't really see that accentuation. But here, it's so much of grabe. So you have pulmonary congestion and later on developed pulmonary edema. Okay, so, okay. So, I think we're now ready. But what's your time now, Doctora Coritana? Doctora Ilani, what's your time?
It's 12:04 na po, Doc.
What in your watch you have
12.
4:50, 4:20?
It's just a background. It's not accurate. That's not accurate.
Sige, okay. Okay. So, what's your time there? What's your time?
12:05 na po, Doc. 12:05.
Oh, 12:05.
Yes,
12:05
Doc.
na. My
Yes,
God,
Doc.
nakaprepare pa naman ako. Hey mo. O sige, sacrifice. 10 minutes. Kaya mo ito. Yani, you will be the one to answer this. Ha?
Ay,
Sige,
sige.
sige, sige. Kaya. Kaya yan. Just wait. Ano na nga din. Ano ba yun nga pag... Ano to pag... Ano pag kunin pa? Ginang ka.
Pag ano, ma-stop and I share ada, Doc. Then screen share again. If iba na PowerPoint.
Sige, adi na.
Sige po, Doc.
May wari ko lang alam no, makuha na po yung oras sa discussion. Okay, answer this in 10 minutes ha. Immediately ha. So, okay, for the review. Part of the reviewer pala, kasi hindi ko pa alam kasi kung ano. Sige, sige ha. Sige, Yani, you'll represent the class. Okay. Just wait. Nakikita? Di pa nakikita yan?
Dire pa, Doc. Nag-share screen ka na po.
Share screen. Oh. Nakikita na. Yan, nakikita na.
It's still loading pa, Doc. Oh, yes, adi na pa, Doc.
Answer.
Okay. Number 1, 760 millimeter mercury.
60, okay, correct. Okay.
Okay.
The layers of gases surrounding a planet, celestial body, atmosphere.
Atmosphere.
Diba? The layer.
Opo.
Yes.
Nitrogen,
the Earth's atmosphere is composed
78%.
78 or 76. 76, 78. Wala dito. It's all right. Next, the Earth's atmosphere is composed of how many percent?
21% for Doc.
Okay. Even at high altitudes, carbon dioxide is continually excreted from the pulmonary blood into the alveoli to all false.
True.
Correct. High altitudes can cause low oxygen saturation or saturation of a person's blood because of low atmospheric pressure at high altitudes.
Low atmospheric pressure. True?
No, correct. Oh. At high altitudes, oxygen molecules are farther apart because there is less pressure.
True.
True. This is false. This is a false scientific medical fact.
None of the above.
None of the above, correct. Which does not happen to your body at high altitude.
None of the above.
Okay, correct. Galing naman ito. Number 10. Kahit gutom eh.
Yeah, true.
Number 11.
The principal means very True.
Okay.
Located in the carotid sinus. True.
Correct.
Peripheral chemistry. True pod. Oh, yes, but true.
14.
Glomerular cells in the peripheral chemistry sense oxygen carbonate. True pod.
Correct.
Carbon dioxide is the most important. True. Number 15 is true. It contains the cardiac respiratory. Medalla oblongata A. And
Okay.
persons
17.
living in altitude 30. So, yeah, true po, Doc. 17 true. 18.
Correct.
Hypoxic
Number 18. It's false.
ordinary person exposed to early and high altitude. None of the above po, Doc.
Correct.
Ay,
Number 19.
okay. 19 hemoglobin of the measures amount of oxygen. True. True 19. The hematocrit measures the amount of space red blood cells. True po, Doc. Number 20. This was
Okay.
okay. The none of the above po is 21. 22.
Okay. 22.
It is true. There is
Elevated.
elevated hematocrit in polycythemia. And 23, 23 to 26 for following it is true po, Doc, yung 23.
Correct.
And
Okay.
acute
Number
mountain
24.
sickness, you can develop acute cerebral edema and acute. True po, Doc, 24. Wala ba, Doc? The following effects are seen in chronic
Correct.
mountain sickness.
Correct. Correct. No mistake.
Elevated. The right side of the heart considered. All of the above po, Doc, in chronic mountain sickness.
Okay. Correct.
26. To get the bench at
Yeah.
18%.
Correct.
Nag-block for leading to heart attacks. True po, Doc. True. 26 is true. When you descend so
Okay.
deep from the sea
27.
surface, you're to diving
Correct.
high pressure. True po, Doc. Number 27.
Correct.
28.
28.
It is needed advice that you should have slower tempo before to let the nitrogen into the alveoli. True po, Doc. 28. Swimming up to quickly
Correct.
to the sea surface after during the session. 29 po, Doc, is true also. And number 30, it is true. Oo, it is 10 feet or 3 meters. 31, abnormal altitude nitrogen in the gas excel to dissolve another gas. So that's true po, Doc, 31. 32.
Okay.
All cases of decompression sickness should be treated initially. True po, Doc. 32.
Correct. Oh, very good. Perfect. Even though you're already, you got perfect, all of you. Okay, so I just don't know kasi how many items. So we'll just have, 30 minutes na lang for pre-Zoom for the rest of the reviewers because I don't know how many items. Because this is so far apart of this, huh? Because others, I
Okay
think,
po, Doc.
Dr. would be requesting to say that. So thank you very much. We'll pray to all of you. Thank you. Congratulations to all of you. In the name of
Thank
the
you po, Doc.
Father, and of the Son, and of the Holy Spirit. Amen. Thank you, Lord Jesus Christ, for the learning. Thank you very much. Our Father in heaven, holy be your name, your kingdom come, your will be done on earth as it is in heaven. Give us this day our daily bread and forgive us our trespasses as we forgive those who trespass against us, and lead us not into temptation, but deliver us from evil. Amen. In the Father, the Son, and the Holy Spirit. Amen. Thank you, doctors. Thank you to all of you.
Thank you, Doc.
Thank you,
God bless you
Doc.
all.
Thank you, Doc.
Thank you,
Dog.
Doc.
Take care.
Bye.
Welcome.
Thank you, Doc.
Bye-bye. Bye-bye.
Bye-bye, Doc. Thank you.
Bye-bye. Bye-bye. Thank you.
Thank you,
They
Doc.
will
Bye,
appear next
Doc.
time. The reviewer.
Okay, thank you.
Bye. Bye-bye.